Hi everyone, good afternoon. Thank you for coming out in the rainy weather today to see Dr. William Klein speak with us. He is here through the Center for Cancer Prevention and Control, as well as the Cancer Outcomes and Health Services Research Group. We're co-sponsoring the talk today. Just a few points of the word that I want, that you should keep in mind. Make sure that you get your tag for lunch after. It will be outside and to the left. Okay? So that bit of housekeeping done, we want to welcome Dr. William Klein. He's, as I said, he is here from the National Cancer Institute. Dr. Bill Klein is the director of the Behavioral Research Program at NCI, the appointment which he began in August of 2009. His research interests are largely in the areas of self-judgment, self-perception, risk perception, and risk communication. And he'll be speaking today about heeding social and self-related motives in attempts to influence health behavior and decision-making. And we are very much looking forward to this talk. You know, as someone in the field of cancer and cancer research, I think it's intriguing to have Dr. Klein here speaking with us about sort of some of the psychosocial aspects of cancer and cancer survivorship. And we thank you for coming to talk with us, Bill.
All right, thank you everybody for being here today, again, especially on a rotten day. It's pretty gross out there, but it's nice in here. I am a social psychologist by training. I found myself working at the National Cancer Institute, and I'm surrounded by people who have a lot of background in cancer and public health and in preventive medicine and so forth. And I do my best to try to keep up with their acronyms and their language. At root, though, I'm a psychologist, and you're going to see that here in this presentation. A lot of the way I think is more psychologically driven. And I have found it to be really interesting and really useful to be able to apply the psychological background to many of the topics that come up in the context of cancer prevention and control. I'm not going to be talking about that hat that I wear at the National Cancer Institute today. I'll be instead talking about my own research over the last 10, 15 years, some of which I have done at NCI and some of which I did before coming to NCI, and much of which I've done with fellows at the National Cancer Institute and the National Human Genome Research Institute, where I also do a fair amount of work. I'm involved with the genetic counseling program there, which is joint between Hopkins and NIH. And in fact, I'm an adjunct faculty member of Hopkins School of Public Health and Health Behavior and Society. So I'm actually, should be a reasonably familiar face, but probably not too familiar because I don't get up here to Baltimore too much. Okay, so what I'd like to do, let's do the right thing here, is start off by saying that when we try to communicate health information to people and get them to change their behavior, we need to acknowledge a lot of what's going on inside their brains. And much of that, of course, is cognitive over there on the left. So how should we communicate the information in a way that will help them make good judgments? To what extent do we need to pay attention to numeracy, the ability to work with numbers? To what extent do we need to think about how people make inferences? That's all cognitive, right? And that's all very important. And in fact, some of my work has been on risk perception, how to communicate risk, and that would fall into that box largely. We also need to think about emotion, and that's not something computers typically have, so that's where we depart from trying to figure out ways to communicate with people relative to communicating with an automaton or a computer. People have emotions, and they bring those emotions to the table, and those emotions can have an impact on how they perceive, how they process health information in ways that often are counterintuitive. And in fact, I give a completely different talk on the effects of emotion on health communication and processing of health communication. And much of that is very important to understand when thinking about how to communicate health information to patients and to the public in general. Where I'd like to focus my attention today is this box, the motivational box. We all bring motivations to the table into every interaction that we're part of. And those motivations potentially color the kinds of information we process, the kinds of information we remember, the way in which we respond to that information and act on it. And so what I want to do is think about the different ways in which these motives might play a role in the health communication context. Some of these motives are motives that have been studied predominantly in decision science. And much of my training and much of my work has been in the area of decision science. And many of the other ones are more social psychological. So they get at self-perception and how people think about the self and how their self-motives might influence the way they think about the world. Those are the ones that are lower on the bottom, are on the bottom of that box there. So jumping right in here, I'm going to talk about 4 motives that come from decision science and 3 that come from social psychology. And I think it's important to think about how all of these potentially play a role in the way that people process health information and the decisions they make about their health. Starting off with loss aversion, you might have seen this before. This is a classic graph developed by Kahneman and Tversky, 2 cognitive psychologists who are now thought of as behavioral economists, but that's because economics in some ways has stolen a lot of what psychology has done and renamed it, put it in new bottles. But really it's old cognitive psychology that gets at how people think about information and how they act on that information. And what this graph gets at is basically 2 important concepts. One is that as you look on the right, as you look at the gains on the x-axis, you can see that as gains increase, the response to those gains tend to be more muted. So an example of that would be if I gave you $10 right now, you'd probably be very happy. If I gave you $20, would you be twice as happy as if I gave you $10? And if I gave you $30, would it continue? No. What would happen over time is that the positive impact of the $10 would wear off, right? So $1,000 is not so much better than $990. And that's why that graph tails off. And the same thing happens with losses. It just tails off. So losing $1,000 is not that different than losing $990. So that's one piece of this. But the second, perhaps more important piece, is that the curve for gains and the curve for losses is different. So what you see is that it's much steeper for losses. Okay? And what that tells us is that people are more averse to losses. We call this loss aversion in the decision science literature. People do not like to lose. And what the literature has shown is that they're more likely to take risks when faced with loss than when faced with gains. So if I ask you to enter a lottery where you potentially could lose nothing as opposed to losing $100, you're more likely to enter that lottery than the reverse, where you have a choice where you would gain money as opposed to losing money. And so that's what this graph gets at, this notion of loss aversion. How can this be applied to health? Well, it has been applied in a number of different ways, and perhaps most interestingly to me, it's been applied to screening. Now screening, think about screening. It's a behavior that potentially involves loss, right? Because one can get bad news from screening, whether it's cancer screening, genetic screening, whatever. And so what this graph tells us is that people are averse to losses. And so if you frame a message about a behavior that involves loss in terms of losses, you might actually get people to do it more easily than if you frame it in terms of gains. And that's been found in a number of studies. The effect is modest. There's a meta-analysis that came out a few years ago showing the effect is fairly modest, but it's still there, and it's a pretty strong signal. One of the studies that I was involved in a couple of years ago, a little more than a couple now, it's 2012 it was published, looked at how such messages about screening could vary not only based on gain and loss, but based on the extent to which people are given a chance to reflect on the affect they would experience once they got those results. We call this affective booster. So here's what we did. We brought people into the laboratory, and this is before I was at NCI, so we had a laboratory at the University of Pittsburgh where I was a faculty member. We brought them in, and these were people who were off schedule for colorectal cancer screening, so they should have screened and they had not. And we gave them a gain frame message or a loss frame message. The gain frame message focused on the gains of screening. Here's what would happen if you screened, okay? And here's what you would gain from screening. And the other message was a loss frame message. So here's what would happen if you don't screen. You might have a polyp. You might be cancerous. Might lead to more negative outcomes. You could have colorectal cancer, et cetera. And what you can see on the left side of this graph, and these are the people in the no affective booster condition. So essentially, it's a control condition that replicates past literature. What you can see, looking at the gray line compared to the red line, is that the loss message led to higher intentions to screen than the gain message. That's the red bar. Okay, so that's just looking on the left. I don't know if I have a pointer here. I do, okay. So comparing these 2 points here, you can see that we replicated past literature showing that for screening, loss-based messages are more effective than gain-based messages. But we were also interested in this affective booster idea, and here's what we did. We simply had people sit in their chair and imagine getting results. So this was an opportunity to engage in imagery, right? How would you feel if you got bad results or good results? And what we found, as you can see here, is that we got rid of this framing difference, that both the gain message and the loss message were equally effective in increasing intentions to screen when people had this opportunity to focus on how they would feel. Okay, so what I'm showing you here is that motivation matters, the motivation to avoid losses, and it may interact with some of our emotional experiences. And this is just one example. We've had several others showing that the motive to avoid loss could interact with other variables, psychological variables, to affect people's intentions. Okay, so moving right along, that's loss aversion. People are averse to lots of different things. As you know, we're averse to the rain, for example. We're averse to loss, and we're also averse to what we might call ambiguity. And this term, ambiguity aversion, was first introduced by Daniel Ellsberg, an economist, some years ago. And what he did is he introduced people to this choice. So imagine you have two urns in front of you. They're both filled with red marbles and black marbles, okay? And you are going to have the opportunity to stick your hand randomly in one of these urns and pick out a marble. If you happen to pick out a red marble, you win, let's say, $1,000, okay? If you pick out a black marble, you don't get anything. All right, so once again, you have two urns here. They're filled with red and black marbles. You're going to randomly stick your hand in one of these urns, and you have to choose which urn. And if you pick out a red marble, you get $1,000. Now, what's the trick here? The trick is that urn A, you can see right in front of you what's going on. You know how many red marbles and black marbles there are. But in urn B, you don't know at all. No idea. Okay? So just by a show of hands, how many of you would choose urn A in this choice? And how many would choose urn B? Nobody. Okay, usually there are one or two risk takers. Most of us do not want to take that risk because what if it turns out there's one red marble or no red marbles in urn B, right? And then you don't win the prize. Well, you're going to feel badly about yourself. You're going to feel potentially embarrassed, right, that you made a bad choice. And that's important because later on I'm going to talk about the importance to people of appearing rational, appearing as if they make good decisions. And people don't feel like they're making a rational decision here when they choose that second urn. So this is what we call ambiguity aversion because urn B is ambiguous. It's not the same thing as uncertainty. Uncertainty, well, you have uncertainty in urn A. You don't know whether you're going to get a red marble or a black marble. You have a 50% chance, and that's uncertainty. Urn B is uncertainty about uncertainty, right? It's second order uncertainty, to use decision science terms. And what that means is that you just have no idea what's going on. And this has been applied to health communication in a number of different ways. What's been found, for example, is that if you give people a range of risk estimates, if you say your chances of breast cancer, if you have the BRCA gene, are between 30 and 80%. Oh, well, that's uncertainty about uncertainty, right? It's a range of risk as opposed to just giving you a point estimate. And people don't often respond very well to that because they don't know what it means, and they're more averse to it. So referring to risk information in this ambiguous way potentially can be counterproductive. Here's another thing we don't like to experience, and we are averse to as much as possible, and we avoid as much as possible, and that is regret. We hate to regret things, and often that drives our decision making. We often think in advance how we're going to feel after the outcome of a decision is known, right? And we think, am I going to regret this? And then that drives our decision now. Sometimes that's not very rational, because whether or not we regret something often does not have anything to do with the quality of the decision that we make. In fact, we experience something called an outcome bias, where we judge the outcome, we judge the quality of our decision making based on the outcome. And sometimes we make perfectly good decisions that just lead to outcomes that are undesirable. That is possible, right? But we don't like to feel regret. And so just an example of that, suppose you're playing blackjack. I don't know if you're familiar with this game. So blackjack is a game where you have to get up to 21, but you can't go over 21. You bust if you go over 21. And so suppose you get a jack and a 6. This means you have, the jack is 10 and the 6 is 6. You add that together, you have 16. And so the question is, do you want the dealer to give you another card? Now, if you get a 5, you are doing great because you got to 21. If you get a 4, okay, you're pretty close, that's still pretty good, but you want to do better than the other player, often the dealer. Okay? If you get a 2, then you're probably going to take it because that only is going to take you up to 18. But of course, if you get something like another jack or an 8, then you're in bad shape because now you've busted and you've lost the game. So when people play this game, they're thinking about the regret they're going to experience when they make that choice, right? Am I going to regret this? Am I going to take a card and bust and then feel badly about it? Well, why am I telling you about blackjack? The reason is because a colleague of mine did something really inventive. This colleague had people play blackjack one of 2 ways. In the first way, it was just like you would in Las Vegas or anywhere else. You have to tell the dealer to give you a card. So that's an action, right? It's an act of commission. You're committing an act. But the other condition of the experiment involved people getting the cards automatically. They had to tell the dealer to stop and not give them a card. So now the act of commission was telling the dealer to stop. Okay? And what they found in this experiment, a very simple experiment, but I think really profound, is that in both of those situations, what mattered most to people was the acts of commission. The people in the control condition who had to ask the dealer for a card, and the people in the other condition where they had to stop the dealer, in both of those cases, they anticipated regretting their decision because an act of commission, actually doing something, can lead to more regret than an act of omission or neglecting to do something. Okay? And this is very relevant to health decisions and health information. An example would be vaccination, right? When parents vaccinate their children, they know they're doing something good, but they're also doing something that will hurt their child. Their child will experience pain because of this needle, right? That's an action, an act of commission. And then parents might hear in the news that, oh, geez, vaccination causes autism and other kinds of problems, which is all fake news, but it's out there, and parents might believe it, and so they might feel nervous and feel like they're going to regret the decision. So in communicating risk information to people, it might be useful to recognize that the way in which it's communicated, whether it leads to an act of omission or commission, might have an impact on the patient's decision making. Last but not least, in terms of motives from decision science, I wanted to talk about the rational actor idea. What we know from decision science is that people want to feel as if they are rational actors. They want to judge themselves as being rational, and they want other people to think that they're rational. And to go back to the Ellsberg paradox just for a moment, let's just put that up here again. One thing that was found with this study is that people were particularly worried about earn B if other people, even just the experimenter, knew how many red and black marbles were in there. Now think about that, right? Why should that matter? It matters because this is unknown information to you, but it's knowable to someone else. And if it's knowable to someone else, that means that you're going to regret it because you're going to be embarrassed. Other people could judge you because they knew something that you didn't know, right? And what was found in some later work is that when people were told that no one knows what's in earn B, they were a little more likely to choose it. Okay, they weren't more likely to choose it than earn A, but they still were more likely. So wanting to be a rational actor, wanting to appear rational seems to be important to people. And I wanted to show you an example of that. Suppose that you have a choice between 2 drugs to address whatever health problem you're trying to address, and suppose that they vary on safety and effectiveness, and suppose further that safety and effectiveness are equivalently important to you. Okay, so this is a case of equipoise. So safety matters just as much as effectiveness, and you've got 2 options here. One that's higher in safety and lower in effectiveness, that's Y, and one that's higher in effectiveness and lower in safety, that's X. What the heck do you do, right? Because again, safety and effectiveness are equally important to you, and you're kind of going back and forth between the 2. Suppose I were to come along, because I'm a nasty decision scientist trying to trick you, and I introduce Z. Now Z is very safe, but not very effective. Now what do we do, right? Well, what's been found is that most people tend to choose Y. And why would they do that? Well, the answer to that is up on the top of the slide. The name of this effect, the compromise effect. The idea is that people feel as if making compromises is a rational thing to do, right? So if someone were to come along and ask you to justify your decision and you said, I chose Y, you could easily say, look, it was the best of both worlds, right? I got safety and effectiveness here. It's somewhere in between X and Z. But you can imagine that this could be used against you, right? Somebody could try to introduce a third option to force you into choosing Y, when in fact X and Y are equivalent in terms of interest. Question?
You're saying in the setting of 3 choices laid out this way, they would choose Y. What about if they only had the 2 choices?
Well, what happens is, in most of these experiments, you're only given X and Y, and then when you have trouble choosing, you get Z in addition to that, secondarily, and that forces people over to Y. But wait, if you think that's interesting, take a look at this. Oops. What if I take Z and I put it in a place where you would never choose it? So look where it is here. It's less safe and less effective than Y. Nobody would ever choose Z, right? So I think you could argue that Z should not have no effect whatsoever on this decision. It's dominated by the other options, X and Y. But what this does here is it makes Y appear more attractive, okay? Because Z compared to X, Z is safer than X. So it's got it over X on one of the elements that matters to you. But compared to Y, it stinks. It's not as safe and it's not as effective. So gee, I'm going to choose Y. Okay, and that's called the attraction effect, because Z is now dominated by Y more easily than X, and so it makes Y appear better. Just imagine how this could be used in a clinical context, right? You have a patient who's deciding between 2 drugs and they're having trouble because they're equivalent on whatever dimensions matter to them. And now you bring in, some other treatment that is not effective and not safe and not worth taking, and suddenly it forces them, it pushes them or nudges them towards another option. That's really interesting. And it's an example of how this rational actor effect can influence decision making. Okay, so what I want to do now is pivot and move from decision science to social psychology and tell you about some of the motives that we've been working on in our research program that we seem to think are very relevant and very important in the way people make decisions and the way in which they process health communications. And I want to start with social comparison. So just to give you an example of the importance of social comparison, an article came out in Time magazine some years ago on sex in America, surprising news from the most important survey since the Kinsey report. This told you what was going on in the United States in terms of people's sexual behavior. And there was a letter to the editor in Time magazine in the next issue, which I thought was really quite revealing. This guy in Minnesota, who I think deserves a degree in psychology, an honorary degree in psychology, says, we Americans are always trying to find out exactly what other people are doing in their lives in order to rate ourselves. Boy, is he right. Because we have a whole history within social psychology of research on social comparison showing that comparison is powerful. We really care about how we compare with others. And we don't even really know how powerful it is, and often don't notice that we're engaging in social comparison. And there are these studies, for example, where they show adolescent girls pictures of models on a screen for, say, 200 milliseconds, and they don't even know they've seen these pictures. And later on, when they're asked to rate their own attractiveness, they rate their attractiveness lower, simply because they've been exposed to these models as a point of reference. Right? And in fact, there's a lot of literature showing that those kinds of magazines are very harmful, and they can lead to all kinds of problems like anorexia and other eating disorders because of the inherent social comparison that takes place when adolescent girls see these pictures. So social comparison is powerful, and I wanted to show you an example of that. This is going back some years to some work I did, very simple experiment in which I asked people to imagine that their chances of causing a car accident were 30% or 60%. Okay, so any rational person would say if your chances of causing a car accident are 60%, you're twice as likely to cause a car accident than if your chances are 30%. Pretty straightforward, right? But I did something else. I also asked people to imagine that their chances of causing a car accident were below the average for their peers or above the average. So that's a social comparison. Okay, this is your chance of causing a car accident relative to people who are just like you. And the dependent variable here was just how safe do you feel as a driver upon hearing this information. And I think perhaps most remarkably what you see here is that all that matters is their social comparison. All that matters is whether their risk is below average or above average. And look where the arrows are. So use the pointer here. If your chances of causing a car accident are 60%, but they're below average, you think you're safer than if your chances are 30% and your chances are above average. Okay, you see what's going on there? All that mattered to people was where they were relative to their peers. The number didn't matter. And you could argue, and I would agree with you, that this is just a problem with numeracy. People don't know what to think about 30% or 60%. But I think that reinforces the point. The point is that social comparison really matters. And one of the reasons it matters so much is because it's a point of reference. It's context, right? Evolutionary theorists would say, of course we compare. If you were a bird in a herd, right? Not in a herd, in a flock, and you were flying through the air and there was a predator coming at you, you damn well should know whether you're the fastest bird in the flock or not, right? That's an important comparison. And birds make those comparisons automatically, just the way we might make similar kinds of comparisons if a lion is running at us and we have to determine whether we're the fastest or slowest person in a group of people. So comparison is evolutionarily important. And you can see here that it really matters to people. So to follow up on this, we did a number of different studies. One of them was to look at whether giving people social comparison information about their risk might influence their intentions to get screened for colorectal cancer. This is again a study with people who were off schedule for colorectal cancer screening. So these are people who really needed to come in and get screened. And we told them that their risk of getting colorectal cancer was above or below average, or they were in a control group where they didn't get that comparison information at all. Now, perhaps the unremarkable piece of this is that if you take a look at the people who were told they had high comparative risk, and these are just two dependent variables, ambivalence and intentions. This is ambivalence about getting screened and intentions to get screened, okay? So if you compare the people who are high comparative risk, that's the blue folks here, they show less ambivalence than those in the control group and also higher intentions than those in the control group to get screened. Okay, so you find out that your risk of getting colorectal cancer is higher than average, and you're more likely to want to get screened than people who are not told that. That's not very remarkable. Perhaps what's more remarkable is what's going on with these people, the gray bar. Those are the people who were told their risk was below average. And they're doing the same thing. Okay? So of course we scratched our heads, this is not what we predicted, and ultimately what we came up with and what we talked about in the discussion section of the paper is the idea that this simply provided context for people. They didn't really know what their risk of colorectal cancer was, but then they find out their risk is below average and they think, oh, okay, that's a good thing. So now I can go in and get screened because I'm reassured it's probably going to turn out just fine, right? And those who were told their risk was above average might say, oh no, I really should go in and get screened because there may be some bad news in the making here, and so I should find out sooner rather than later. And so what this seems to reinforce, and that was all post hoc, by the way, that was the discussion section of our paper, but what this seems to reinforce is that comparison information provides important context for people and might drive their behavior, irrespective of what it is. Simply giving the comparison information might be impactful. Now, how might this play out in an impactful way? Well, there are a lot of risk engines on the internet where you can just go to a website, put in all your risk factors for some disease, and it spits out a number and says your risk of diabetes is 20.3%, or maybe a range like 20.3% to 30.3%, going back to my ambiguity aversion example. Well, there's one site out there developed by Graham Colditz at Harvard University, now at Siteman Cancer Center in St. Louis, which only gives people comparative feedback. And you actually have to really dig to get the absolute feedback, the absolute numbers. All it tells you is whether your risk is above average or below average, or perhaps much above average or much below average. They use those terms as well. And you can see that example here. I went through this website myself. I plugged in some risk factors. I made up a few. And here I found out that my risk was above average. That's because I made up a few of the risk factors. And also I can check to see how that might change by clicking some of these things over here. But the key is that people are being told what their risk is relative to others. So the next question would be, okay, does that have an impact? Does it make any difference on people's behavior? So we followed up on that, a group of colleagues, including one of my fellows at the National Cancer Institute, in which we gave people this kind of feedback using that website about their cancer risk. And then we looked at various health cognitions related to physical activity. And you can see three of them here. Intentions to engage in more physical activity, self-efficacy to do so, and response efficacy, which is a term that gets at the belief that physical activity actually will reduce one's risk. Okay? And as you can see, for all three of these dependent variables, when people were told their comparative risk, they were higher. They had higher intentions to engage in physical activity, higher self-efficacy, higher response efficacy relative to a control group that just got basic information about risk and were not told what their comparative risk was. So this does seem to suggest that giving people that comparative kind of information from a risk engine, like the one that I showed you, might have an impact. It's not a huge impact. I mean, these bars are not that different, but it potentially gives us some useful information upon which to base feedback and output from such a risk engine. So let's now talk about self-enhancement, because self-enhancement is highly related to social comparison. We don't just compare with others. We compare with others with kind of an edge. We like to compare well with others. We don't want to think that we are the slowest runner or perhaps the slowest bird in the flock. We like to think that we're pretty darn good relative to others. And in fact, there's a lot of evidence in the literature that people think they're better than average on many different dimensions. And just to give you a couple of fun examples, 97% of college professors think that they're above average teachers. 97%. Now, sure, distributions can be skewed, but that's really not plausible, that 97% of teachers are above average teachers, right? In another study, those of you who might remember way back when you took the SATs in high school, there are questions in there that ask you how good you are relative to your high school peers on a whole set of dimensions, leadership ability, writing, etc. If you take a look at those numbers, now of course it's a select sample, right? These are people who are applying to take the SAT, so that's not a representative sample of all high school students. But nevertheless, over 95% of students who fill this out think they're above average. Okay, so it's just like the college professors. They think they're great, and they not only think they're great, but they're better than other people. And we see this across the spectrum. 90% of drivers think they're better than average drivers. What happens when you get out on the street, you know, and everyone's driving and they all think they're better than you? They think they're better drivers than you are. That potentially has implications for accident risk, right? So we have these beliefs. We think that we're better than average on many different dimensions. And just as importantly, we tend to be unrealistically optimistic about our future risk, which is something that was discovered by Neil Weinstein back in 1980. And it's been followed up in many studies since. We simply just don't perceive that bad things can happen to us. We've heard this before, right? Bad things happen to bad people, good things happen to good people. I'm a good person, so it ain't gonna happen to me. It's gonna happen to somebody else. And so we might underestimate our risk. And those kinds of biases can be problematic because they can lead to beliefs and behaviors that actually unwittingly increase people's risk, right? And I've been involved in a couple of different studies where we found that people who are unrealistically optimistic processed health information less effectively, they were less likely to change their behavior, etc. So these biases might potentially be a problem. So what should we do about it, right? Well, my naive view of this, back when I was first doing this research, is let's just get rid of the bias. Let's get these people in a room and say, you shouldn't be biased, this is a bad thing. Give them information that'll change their bias. No, that doesn't work. And of course, that was terribly naive. And in fact, I even published a paper in the journal Health Psychology some years ago with a colleague, Neil Weinstein, in fact, in which we published 4 or 5 failures to reduce unrealistic optimism. And it's very rare, at least back then, to be able to publish studies that don't work. But it was so striking that we went out of our way to try to reduce this bias and failed every time. And in some cases, we made it worse. We made the bias worse. And the editor thought that was pretty cool, so we got the paper published. So how do we address this? If it's problematic, how do we address it? And I'm going to give you a couple of examples of that we have looked at. So one example is to think about using proxy messages, or messages that are not designed for you, but designed for someone that you have some influence over. So those of you who are married, think about your spouse, and think about times that your spouse really needed to change their behavior, right? And what role did you potentially play in that? Well, that's kind of the theme behind this next study that we did, which just came out last year. This is a study with Rebecca Ferrer, a colleague of mine at NCI, in which what we did is we gave men and women messages about cancer risk. The messages themselves were focused on a cancer risk that was either gender specific to them or to their spouse. Okay, so the women got messages about breast cancer risk or about prostate cancer risk. And the men, again, same thing. They got messages about breast cancer risk or prostate cancer risk. In both cases, both messages, it was about weight. It was about being overweight, and the idea that being overweight, being obese, can increase one's cancer risk. So again, think about this. You're a woman who gets a message about how being overweight can increase breast cancer risk, clearly relevant to you as a woman, or prostate cancer risk, clearly relevant to your husband, okay? Or the reverse, we have men who get both messages. And I should say, we probably all know that men can get breast cancer as well, but the frequency is much lower. So for most men, they don't think of that message as being very relevant to them. The question now is, how much does this message worry the recipient of the message and lead them to engage in behavior? And we had a bunch of dependent variables, but I just want to show you 2 exemplar dependent variables to give you a sense of what we found. So the control group, that's the red bar, those are folks who are not given a threatening message at all. Okay, so that's simply a referent. And what you can see is that when people got a self message, so that's the gray bar, okay? The self message is when the women got the breast cancer message and the men got the prostate cancer message. And what you can see is that those gray bars are not very different than the red bars. There's a little bit of a difference here in talking to the provider, which is one potential behavioral outcome, and no difference here in worry. Where we got an effect was when the proxy got the message, okay? So the proxy, that would be the woman getting the prostate message, so now needs to talk to her husband about his weight, or the men getting the breast cancer message. And what you can see is that that did increase worry and also increased intentions to talk to a provider. By the way, one of our dependent variables was talking to your spouse about the results. We got the complete opposite effect there. Okay? So women, when finding out that their husbands potentially were increasing their risk because of their weight, had absolutely no interest in talking to him about it. And it was even stronger on the other side, right? Men did not want to talk to their wives about losing weight. Duh, you know, we should have figured that out early on. So not surprising that we got that. But we did get differences on other behaviors, such as talking to a provider. And another one was shopping, right? You don't have to talk to your spouse about losing weight, but what you can do is get engaged in the shopping and buy healthier foods. That's a little more indirect and potentially can have the same kind of effect. Okay?
So is there a statistical measure for these differences?
I should have done that. I was trying to keep things simple. These are significant differences at 0.05, I think based on an ANOVA. And we had a sample size of, I think about 300 people. I'd have to go back and take a look at it. This was done, by the way, using mechanical mTurk. So this is an online sample through Amazon that you can get, and we were able to screen people based on their weight and whether they were married or not or had a close other, and whether they met some other criteria. So it was a useful way to collect data. Okay, so that's one thing I can do, is try to use a proxy message. Another thing I could try to do is reduce the bias. But I've already intimated that that's a hard thing to do, really hard to do, and we've tried it many times and failed miserably. But maybe we shouldn't have been trying to do that in the first place. This goes back to me being very naive. And I hope all of us have one of these experiences in our career where we go back and look at an idea we had and say, what the heck was I thinking, right? And this is certainly an example of that for me. And why? Because in looking at some other data, we have found, and others have as well, that these kinds of biases might actually be a good thing. So this is just one example. These are data collected from a large sample in the United States in which people were asked what their chances of getting cancer were, and then 10 years later, we were able to follow up and see whether they got cancer. What a perfect way to assess unrealistic optimism, right? We can get people who say they're not going to get cancer, and then 10 years later, they got cancer. So those are people who are essentially unrealistically optimistic. They're underestimating the risk of getting cancer. What we see here on 2 different measures, affective well-being and life satisfaction, is that 10 years later, the people who perceived that their cancer risk was high, okay, and they eventually did get cancer. So these are realistic people, people who said, yep, I'm going to get it. And 10 years later, they got it, okay? Those people are suffering. Their affective well-being is not so hot, and their life satisfaction is not so hot. Take a look at these people. These are the people who thought their risk was pretty low, and they got cancer in that 10-year period. How are they doing? Pretty darn good. Their affective well-being is pretty good, and their life satisfaction is pretty good. And this is just one example. There are many examples in the literature showing that being unrealistically optimistic, underestimating risk, might have mental health and other benefits down the line that really preserve life, right? So what that suggests is that reducing the bias may not be the smartest thing to do, okay? And so one thing we might consider doing instead is not to reduce the bias, but to reduce the effects of the bias. What can we do to try to affect the downstream implications of unrealistic optimism? And that gets me to the last item on this list here, value affirmation. So there's a whole literature in social psychology showing that people really care about appearing as moral, people with integrity, who are consistent, who can be depended upon, who have a good ethical backbone, etc. And that's really what matters to people the most. And to the extent that they can preserve that feeling, then they can deal with threats more easily. And so several studies in this literature have shown that if you threaten people in some way, like you tell them that they don't exercise enough, or you give them a bad test score, or whatever it is you might do, often the reaction might be very defensive. Oh, I got a bad test score because, you know, the weather was bad, or because I didn't have a good night's sleep. And they come up with excuses. Or the reason I don't engage in physical activity is because I do lots of other healthy things that keep me healthy, right? And there's a big literature on how people engage in these defensive processes to justify their behavior. What this affirmation literature shows is that if you simply give people a chance to reflect on their values and remind them they have integrity and they're moral and they're ethical and so forth, they don't show those defensive processes quite as much. Okay? They're less defensive and more open to these kinds of threats. So what we thought is, what if we try to meld this value affirmation idea together with unrealistic optimism and see if, in fact, affirming people's values and helping them to feel ethical and valued and so forth maybe will reduce this effect, this negative effect of unrealistic optimism. So let me give you two examples. In one of them, we took people who varied in their perceptions of how ambiguous cancer messages were. We have a survey we do at the National Cancer Institute called the Health Information National Trend Survey, or HINTS is the acronym. And we ask people questions like, to what extent do you think there are too many messages about preventing cancer? And do you think that everything causes cancer? That's another item. And what you find is that there's a lot of individual difference there, a lot of individual variability. Some people say, yeah, everything causes cancer, and I don't know what to believe because everything recommends, you know, do this, do that. There's no clear recommendation about how to prevent cancer. Other people don't believe that. So we broke those people into two groups, people who perceived low ambiguity in cancer messages and high ambiguity in cancer messages. And then we did the self-affirmation thing that we ripped off from the literature, where we had them just reflect on some of their values to remind them who they were and what mattered to them, okay? And what you can see here is that for people who didn't perceive a lot of ambiguity, these are people who don't really, they're not that all that upset about all the messages out there to prevent cancer. And so they're not really threatened. And so we didn't really expect much of an effect of self-affirmation for them. And we didn't get one. But look what happens here. When you self-affirm people who perceive high ambiguity in cancer messages, they accept a message much more. And I should have told you what the dependent variable was. We gave them a very clear, unambiguous message about the link between alcohol and breast cancer, and looked to see how much they accepted that message. I should have told you that before. And what you can see here is that message acceptance for that message was higher when those individuals were self-affirmed. So there's a signal here. There's some sense that giving people a chance to reflect on their values makes them less defensive in response to potentially threatening messages. Another example. So this is another study where we had people who are off schedule for colorectal cancer screening. This typically is a group of people who are over 50 and have not gone in to get their screening test. And once you're over 50, you got to go in and do this thing. It's not fun. You have to drink this horrible liquid. And it's a very invasive test, involves anesthesia. People don't like it very much, but it's really the best way to detect colorectal cancer. People can do other kinds of tests that are a little less effective, but that's sort of considered the gold standard. So we brought people in, we told them about their risk of colorectal cancer and hoped that that would motivate them to go in and get screened. And this is simply a look at their intentions to get screened right after we gave them the information. We had a non-affirmed condition and a control condition, and those were effectively the same. I'm not going to talk about the difference here in the interest of time, but you can see that their intentions were pretty similar. What matters is the self-affirmation condition. Those are people who had a chance to affirm their values prior to getting the information about their colorectal cancer risk. And what you can see here is that they showed higher intentions to get screened. And I want to point out here that in this case, they didn't just focus on general values, they focused on their health. We asked them to talk about things they do to maintain good health. So it was really focused on health in particular. And even that was successful enough at leading to this higher level of intentions to get screened. Last example, this is some work I'm doing with NHGRI, the National Human Genome Research Institute at NIH, in which we have access to a large sample in the Maryland area of people who have had their exomes sequenced. So this is DNA sequencing. We have all this information about their genetic risk, and they have the opportunity to get this information. They don't have to get it. The information is simply being collected for medical, for research reasons, but they have the opportunity to get this information if they want to. And so some of my colleagues and I have incorporated behavioral and social questions into some of the surveys that the participants in this exome sequencing cohort have been given. And some of them involve constructs that I've talked about already in this presentation, including self-affirmation. So we asked people, using a validated measure of self-affirmation, how often they self-affirm. Is this something they do often in everyday life? And then we look to see how that might influence their engagement with health information. So let me talk you through this. The dependent variable is their intentions to learn their results, particularly for medically actionable disease. So these are genetic results that people would get and they could do something with them. Okay? We also asked about non-actionable disease, but don't have time to get into that. And the results were pretty similar. So we also have information avoidance tendencies down here. We had a measure in there that looked at how often people avoid health information. And let's face it, some of us do that more than others, right? And we had individual variability here, such that some people were higher in information avoidance than others. So what we see is that for people who are lower in information avoidance, there's not much of a difference here. And also for people who are high in information avoidance, there's not much of a difference. But if you take a look at the slopes, what you see is that those who are high in self-affirmation, that is to say those who affirm quite a bit, they focus on their values, there's not much of a difference in their information avoidance tendencies in the extent to which that predicts their intentions to learn their results. But those who are low in affirmation, that's this line here, that's a significant slope. And what that suggests is that if you're not someone who focuses on your values, then information avoidance tendencies get in the way of you seeking out these genetic test results. This is just one finding, and it's not a strong finding, but it's a signal that we have replicated in a number of other analyses, suggesting that affirmation can offset the effects of defensiveness. Okay, so I've talked about a number of different motives here. I just want to mention that there are many others out there that I could have talked about, and in the interest of time, I did not. But here are a few that have been looked at in the literature. Predictability. We are motivated to think of the world as predictable, and that's why, in fact, victims are often blamed. Right? Because if we blame victims for their outcomes, it's easier for us to think that the world is a predictable place where bad things happen to bad people and good things happen to good people. And there's a big literature on that. We also like to feel we have control, and there's even an illusion of control. We often think we control things that we do not, like me as a parent of teenagers, for example, but that's besides the point. And often that can get us in trouble because we're motivated to control things that are not very controllable. If you're on an airplane that's being hijacked and there's not much you can do about it, there are other coping strategies that might be more effective than trying to exert control. Also, our motives towards health. Some people have a promotion motive, they want to maintain good health, and some people have a prevention motive, they want to prevent poor health. And you can make that distinction and show that that can have an impact on people's behavior. And so there's a literature on this as well. And what it suggests is that if you have a health promotion focused person in front of you, you should focus on health promotion. If you have a prevention focused person, you should focus on prevention. And some studies have shown that if you mismatch the messages, you give a prevention message to a promotion person, it doesn't have as an effective an impact on their behavior. And so that's something that's worth knowing about as well. All right, so some basic conclusions. I hope I've convinced you that self-related and social motives matter when designing health communications. There's something that you need to pay attention to, obviously, as a clinician, for example, because they're in the room there. They're hovering over people as they process information and make decisions. This is true of many different kinds of health communications. An example would be warning labels. So the FDA has worked on trying to develop graphic warning labels for cigarette packs. Their first round of doing this didn't work very well because the court struck them down, and now they're working on another set, and hopefully we will have a new set at some point in the future. And that set will be built based on the existing literature on how people process health communications, partly some of the work that I've talked about here. We also need more work that integrates decision science, motivational science, and health communication. All of these fields have something to say about people's behavior, but from where I sit, and I've seen this even more as an employee at the National Cancer Institute, members of these fields don't often necessarily collaborate with each other or talk to each other. And sometimes they even describe the same phenomenon with different terminology and study it in different ways. And we need to understand why that happens and do something about it. And I consider that part of my job at NIH to try to connect the dots and get people to talk to each other and work together. So let me end by thanking the funders of this research, the National Cancer Institute, also National Science Foundation, Prevent Cancer Foundation, and some of my principal collaborators here. And I'll tell you also that, wearing my other hat, if you're interested in what we're doing at the Behavioral Research Program at NCI, we have a nice Twitter account here that you're welcome to connect to. We also have a newsletter that you can sign up for. And I think that's it. Yes. So I will stop there and take your questions.
I'll bring the microphone around, but just raise your hand and we'll let you have a chance.
Hi, David Myers here. Can you talk a little bit about the vaccine conundrum, which seems to be quite resistant among certain populations? What would be your ideal approach to converting non-vaccinators to vaccinators, parents in particular? What do you think is the best approach on a mass level as opposed to sitting down individual by individual, if that is possible to do it at a mass level?
Yeah,
and I'd also just make the point that there's a lot of political ramifications too, about political choices and behavior as well.
Really interesting question, and something we've been excited about because it's not only about typical vaccinations that we normally think about, but also HPV vaccination. And HPV vaccination is a very important preventive technique for cancer, for cervical cancer. So we've been spending a lot of time thinking about this. What the literature seems to be showing, and we had a recent meeting on misinformation and false information in health in which this came up again and again, is that correcting people's beliefs about vaccination is not the way to go, and in fact can make things worse. And we probably have all seen examples of this where we tried to correct someone's misinformation about something, and lo and behold, they think even more strongly in whatever they started with, right? I see nodding heads, you know what I'm talking about, back to my being a parent of teenagers. What really does work? Well, it turns out that when people are anti-vaxxers or anti-anything medical establishment, often it's not about their knowledge or their attitudes or about the information, it's about a social identity. And you have to address that social identity. This is coming up again and again in this literature. And what it suggests is that you need to address that identity. And to the extent that you can do that, and how, of course, is the difficult part, you might be more successful at changing their attitudes. And more importantly, since their attitudes are not predictive of their behavior, changing their behavior. And so a lot of work is now being put into this. How do you get at those kinds of individuals, maintaining their identity, maybe using self-affirmation, for example, and then changing their behavior in ways that don't threaten their identity anymore. Giving them information, all that does is it says, you're wrong, and your identity is wrong. It's like telling smokers that smoking causes lung cancer. Duh, you know, they know that. All you're doing is making them feel badly, and that doesn't help at all. It causes more anxiety, which makes them want to smoke. You know, and so it doesn't lead to the outcome that you desire. So getting at the identity seems to really make a difference.
Is that also true for the lung cancer screening among smokers, getting them to adopt the low-dose CT scan?
Yeah, I haven't seen any work on social identity per se with regard to screening, but the fact of the matter is that smokers don't really understand what screening is, what computed tomography is, and whether it's relevant to them. And I showed you that risk engine earlier. Those risk engines are typically designed for people who are relatively high in socioeconomic status, right, and can understand them. most smokers these days, if you take a look at the stats, are lower in socioeconomic status. And those risk engines, which are being designed to give people information about their risk of lung cancer and whether they're eligible for screening, they're incomprehensible to someone who is not highly educated. And so it's a major concern, right? How do we get the right information to smokers so they know whether or not they're eligible? And how do we get providers to use that test appropriately? Because it's also being used in smokers who are not 30-pack year smokers and should not be getting screened.
Thanks.
Hi, Deborah.
That was great. I loved your talk, and I was thinking about the Lake Wobegon effect, which is not just the optimistic bias that you were talking about. I believe that I'm a better teacher than others.
We all are.
We all are. But the corollary to that is that I also believe that my doctors are above average. And we've done, Judy Hall and I've done a number of studies where we look at that, because people are skeptical of doctors and medical institutions and credibility of, treatments, except they believe that their doctors are above average. And so I was really intrigued in trying to think through, how do you use affirmation in a way that is personally directed to diminish some of that negative impact of that optimistic bias, but also halo it to, or maybe it's not been done, to others in your social network that you are attributing, higher performance and competence, and, who may be telling you in your social network inconsistent with facts information, or
Yeah.
So it's really an interesting conundrum to be thinking about it multidimensionally in terms of self, but also others.
Yeah, it's a really good question. I have to tell you, by the way, that I often call that effect the Lake Wobegon effect, and I've stopped doing that because Garrison Keillor is not exactly the most savory character anymore. But that effectively is the Lake Wobegon effect. All the children are above average. And so with regard to the question, some investigators recently have started tinkering with the self-affirmation idea at a social level, at a group level, or what you might call group affirmation. For example, a self-affirmation might be focus on things you've done in the past that are honest and that contribute to society and so forth. But a group affirmation might be focus on what your group has done to make the world a better place. Focus on your identity as a member of this ethnic group, racial group, whatever. And I have to say, the literature is in its nascent stage, so we don't really know how to do that right yet. We don't know how to do group affirmation in a way that's effective. But I think it has some legs. And it might be the case that affirming people's social identity or affirming their group membership might have more pervasive effects over members of their social network and the way in which they communicate with them and the way in which they think about them than a self-affirmation would. So that's going in one direction. The other question is, how do you get at people's beliefs about others, their overestimations of others? And all parents think their kids are better than average. All teachers think that their students might be better than average. I mean, these sort of things are pervasive. And what's been shown is that that's not just motivated, it's also cognitive. People in one study were shown apples, and they were asked, how does this apple compare to the other 5 apples? And in general, they thought that apple was better than average, and it didn't matter which of the 5 apples they were asked to rate. So there's a cognitive phenomenon here whereby when people are focused on one particular object, they tend to rate it as deviant, as different than the others. And so there's something else going on there that needs to be addressed as well. But I think it's a really interesting question, and I think we need more research on it. Yeah.
Hi. I'm wondering if you talked about a whole slew of messaging types, and I'm wondering if any of those particular messages, if the recipients of the messages change their response to the messages depending if the potential health outcome was on different temporal scales. So a more short-term potential health outcome versus long-term, whether there is more or less response.
Interesting. So So an outcome that would happen 20 years down the road as opposed to
Right.
something that might happen tomorrow?
Right.
Yeah, no, that's a really interesting question. And I think it's a major drawback of the literature. I think a lot of these kinds of studies, they're done by decision scientists and psychologists who bring people into their labs, and it's a 30-minute experiment, and the outcome variable is measured at the end of the 30 minutes, and then they go off on their way. There are fewer longitudinal studies. But I would say that I think this is a really important research question. To what extent are these kinds of phenomena different when looking at long-term outcomes as opposed to short-term outcomes? And if you think about the colorectal cancer studies that I've done, screening is a proximal outcome, but colorectal cancer is a much more distal outcome. And trying to get your head around whether that matters or not, whether the proximity to the outcome matters, I think it's an interesting question that has just not been addressed as much as it should have.
Okay, thank you.
Sure.
Are these results consistent when you repeat them on the same individual over time?
So if the experiment is repeated on the same individuals on specific intervals, are they consistent? Are they reliable?
Yeah, good question. So the question is, to what extent are these effects consistent within an individual over time? And I can tell you there's not really enough data to have any firm conclusion about that. But in the few studies we've done where we have gone back to people and reassessed the effects over time, they seem to be pretty strong. Self-affirmation effects, for example, are pretty strong over time. Loss aversion, regret aversion, those kinds of things, you tend to see that a lot over time. But there are age-related changes. Tom Gilovich at Cornell University shows that regret changes over the lifespan. So young people, they regret the things that they do. But older people regret the things they didn't do. Right? So acts of commission and acts of omission lead to differential levels of regret based on age. And so that's really interesting to think about when you're thinking about healthcare. If you have young patients versus older patients, what's the impact of making recommendations about health decisions they might make on their regret and their experience of regret? So really interesting question. I think one that really deserves more attention.
We're at time, everyone, so we're going to end here. But we will have lunch outside, and Dr. Klein will be sticking around, and certainly you can ask any questions that you have. I'd like to just say thank you from our centers, the Center for the Cancer Center, and the Cancer Outcomes and Health Services Research Group, and thank you for taking the time and coming to speak with us today, and we look forward to continuing our conversations.
My pleasure. Thank you.